Welcome to today's Fern learning session on brain biomarkers and the evaluation of ED patients with mild traumatic brain injury. What is the pathology? What is the clinical benefit of this diagnostic test? And what role does this lab have in 2026? My name is Edward Sloan. I'm Professor Emeritus in the Department of Emergency Medicine, U of I in Chicago. I'm also Medical Director of the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This is the QR code for my information, and I want to thank the people from the Emergencies in Medicine Educational Group who helped provide this original presentation. I have no financial conflicts. I'm Fern President and Board Chair. You can join us at fern.org or on social media. And at YouTube, you can join us at Fern.org, where we have several different playlists, shorts, and longer presentations. This information is available to you using this QR code, and there is extended information including a policy brief, clinical update, and mild traumatic brain injury patient information using this QR code. So let's talk a little bit about these platforms and how they provide value to the clinician in the emergency setting. So what two specific blood biomarkers are FDA cleared for CT evaluation? We know that GFAP is astrocyte structural protein and UCH-L1 is neuronal specific enzyme that is released. The FDA has cleared two assays. One, the Banyan-Vitis Brain Trauma Indicator, marketed and owned by Biomarkers, and Abbott's iStat Alinity platform. Again, these are multiplex assays that test both of these biomarkers over just a single biomarker, one versus the other. So what is the patient population for the use of these brain and blood biomarkers? It is designed for adult patients 18 years or older with mild traumatic brain injury with a GCS of 13 to 15 and testing occurring within 12 hours of injury. And it's indicated for the safe deferral of non-contrast CT when these biomarkers are negative in what are considered to be low-risk adults. Again, this is not a test that can be used to predict the presence of a concussion or long-term symptoms or their resolution. So what are the clinical results and cutoffs that we see? What are the cutoffs and interpretation for these blood-brain biomarkers? You can see that with the Abbott iStat test, these are the cutoffs that are noted, and if either of the levels is above these thresholds, the test is then considered positive and a non-contrast CT is advised. If both levels are below these cutoffs, then the test is considered to be negative and CT may be avoided. We are looking now at the Banyan Brain Trauma Indicator platform. And again, there are cutoffs that are very similar to those seen with the Abbott platform. If either of the lab results is above the cutoff, then the test is positive, CT may be advised. And if both are below, then the test is considered to be negative and CT may be avoided. So what is the performance of these two blood biomarkers for detecting a positive CT? In summary, these blood-brain biomarkers are high sensitivity and have a high negative predictive value for the non-contrast CT being positive for some identified traumatic lesion. We note that the sensitivity is 95 to 98% and the negative predictive value is 98 to 99%, quite high. But we do recognize that the specificity is quite low, 35 to 60%, because there will be many false positive results in this lab test, suggesting the need for a non-contrast CT. But from a clinician's perspective, this is not a problem. These might have been patients that they would have CT'd regardless based on their own clinical suspicion for a traumatic brain injury present on CT. Continuing with our understanding about performance, the area under the curve performance of these two biomarkers is quite high. The AUC is 0.82, and anytime you have 0.8 to 0.9 as an AUC value, that suggests excellent discrimination and a strong diagnostic value. We know, again, that there's high sensitivity and few false negatives, but we do recognize that specificity is low and false positives do occur perhaps in 1 out of every 2 lab tests that are performed. So let's talk more about biomarker negative predictive value in the setting of mild traumatic brain injury. It is important to note that negative predictive value is dependent on disease prevalence, and the NPV will change depending on how prevalent the outcome is in the patient population. That is to say, sensitivity is a reflection or a characteristic of the test itself that never varies. However, negative predictive value can be quite high when the prevalence of, for example, lesions on CT is low, and that negative predictive value can drop in a patient population with a much higher prevalence of CT findings indicating traumatic brain injury. So, what was the prevalence of intracranial lesions in the study populations that led to the approval of these lab tests? The range of CT findings that are positive was about 5 to 12%. In the Banyan trial, 12%. In the Abbott trial, 8 to 10%. So we know that the majority, perhaps 90% of the patients, had no intracranial lesion on non-contrast CT. This allows negative predictive value to be quite high, and then the sensitivity for the test is going to be good because fewer patients actually have a lesion on non-contrast CT. But remember, negative predictive value will decrease if the prevalence of lesions in this population rises above the trial levels, in other words, greater than perhaps 15 or 20%. So let's talk a little bit about the ALERT-TBI trial. This trial led to the Banyan approval. It was published in Lancet. It's important to understand what were the CNS lesions detected on head CT in patients with a negative biomarker test. In other words, what were the false negative patients from the ALERT-TBI study? There were almost 2,000 patients studied from this clinical trial, and 6% had CT detected intracranial lesions. We know that 2/3 had a positive test result, and about one third had a negative test result. So what did we find? We know from the ALERT-TBI trial that the sensitivity was 98% for detecting intracranial lesions. The negative predictive value approached 100%, quite good. But there were 3, less than 1%, of the 2,000 patients in whom the CT scan was positive, creating a false negative lab biomarker test. One patient had a small subdural hematoma, which was non-surgical. The patient was clinically stable. One patient had a subarachnoid hemorrhage, which was considered to be minimal, not requiring any intervention. And one patient had a non-displaced skull fracture without any intracranial complications. All 3 were considered to be minor, and they were non-operative findings. None required any neurosurgical intervention, and all 3 patients had favorable outcomes. Now, it's important to consider these are important lesions, and many clinicians would say, I need to be able to detect these on CT, And if that's the case, the use of these brain biomarker labs will be less than it could be otherwise, because clinicians are concerned and want to be able to detect this type of injury, even if they are mild, even if there was no neurosurgical intervention, and even if the patient had a favorable outcome. Now, what about the causes and the recommendations about missed lesions? What types of CNS lesions are detected on non-contrast CT in patients when their negative biomarker test occurs? Well, there may be microscopic hemorrhages that aren't necessarily detected on CT, but might be detected on MR. There might be very small cerebral contusions or very early lesions that can occur before or after the initial blood biomarker test is obtained. Diffuse axonal injury can occur and be negative on CT and positive on MR. And there may be some issues related to the lab assay itself that may cause there to be false negative lab biomarker results. And so we know that biomarkers are designed to rule out the presence of non-contrast CT lesions in low-risk mTBI adults. And we know that the role of these biomarker labs diminishes as the pretest probability of a intracranial injury increases, and as the clinician's concern regarding the possible presence of lesions is elevated to the point that the patient is no longer considered a low-risk patient. These end up being important confounders in the clinical setting. What types of CNS lesions may be detected on head non-contrast CT in patients with negative biomarker testing? And to what end? What is the significance of these? There may also be anatomically small posterior fossa injuries that may not immediately elicit a strong biomarker release. When there is persistent severe vertigo, ataxia, cranial nerve findings, or anticoagulant status that is positive, these may indicate the need for neuroimaging regardless of the biomarker test result. And it is of note that protocols should codify when non-contrast CT should be done first in order to maintain patient safety and medical legal defensibility, because the patient is considered to be not low risk, but moderate or high risk. So we conclude, some brain injuries can occur without brain biomarker release. And we know that brain biomarker release relates to non-contrast CT need, not to the absolute brain injury per se. We know that negative biomarkers can supplement clinical judgment regarding the need for neuroimaging acutely, but we know also that these brain biomarkers do not indicate the presence of a concussion, the duration of symptoms, and whether or not these symptoms will completely resolve over time. So in conclusion, clinical context and decision-making by the clinician still are essential elements in the evaluation of mTBI patients when considering brain biomarker lab testing and non-contrast CT neuroimaging. So, how long does it take to get the results from these brain biomarker lab tests, because that influences their utility in the clinical setting? The turnaround time varies by platform. Point-of-care platforms allow the biomarker results to be obtained in 15 to 20 markers, and those that are automated immunoassays, these analyzers take about 30 to 45 minutes from receipt, and we know it does take some time for the blood to go from the emergency department to the lab for testing. So the question for the clinician is, can biomarker results return faster than a CT in your ED? And can ED patients be discharged faster when no CT is performed and only a lab biomarker test is performed in your individual emergency department. So what is the utility of these lab tests in the context of CT head decision rules, which are commonly used? This modified Canadian CT head rule for mild head injury is listed, and the question is, how does biomarker testing fit in when these decision rules are used? We do know that biomarker testing does add objective data when the decision rule itself yields uncertain risk. In other words, if a patient may be low risk, biomarker testing that's negative will confirm their low risk status. If it's uncertain and the biomarker lab test is positive, you then may say that the patient is moderate risk and neuroimaging is indicated. We do know that these lab biomarkers are 95 to 98% sensitive, such that when the lab test is negative, it is not likely that there will be many patients who will have undetected CNS lesions because no neuroimaging was performed. So, we know that the Canadian CT head rule clarifies mild traumatic brain injury management, and we know that the lab data adds objective information to this process. So what is the utility with regard to CT use reduction? We know that the protocolized use of these brain biomarkers in low-risk adult mTBI patients can reduce CT use by 20 to 30% when implemented in the clinical setting. This means there will be less radiation, about 2 millisieverts per patient, which is about 8 months of background radiation. And we know that there will be less false positive detection of clinically insignificant CT findings, such as a calcified meningioma, which really does not impart any outcome variance for patients. What about ED throughput? Is it faster with the use of brain biomarkers? We know that brain biomarkers can be returned in as short as 15 minutes with point-of-care use, and we know that non-contrast CT head use can be reduced by 20 to 30%. If in emergency departments the point-of-care testing is provided, there can be a significant decrease in ED length of stay by an average of 45 minutes and around 30 to 90 minutes overall if this point-of-care test is negative, indicating no need for non-contrast CT. So what about pediatric biomarker performance? What's the performance of these two blood-brain biomarkers for detecting a positive CT in pediatric patients? One study published in Lancet Child and Adolescent Health recently indicated 100% sensitivity and 67% specificity using these lab tests, and the negative predictive value in this study was 100%, suggesting that children with a negative biomarker result could safely be discharged home without having to provide non-contrast CT scanning. So again, another study in the International Journal of Emergency Medicine demonstrated a sensitivity greater than or near 100% and a negative predictive value greater than 95%. As was seen in adult patients, we note that specificity is modest, meaning there will be false positives that indicate the need for CT scanning, but overall still it may be possible to reduce the overall number of non-contrast CTs needing to be performed in low-risk pediatric patients with mild traumatic brain injury. For more information, go to fern.org, where you can find content relevant to your clinical practice. We're also available on social media and on YouTube at fern.org. You can find playlists and video content that will improve your patient care, patient outcomes, and your clinical practice. So with that, I'd like to thank you. And if you have any questions, you can email me at my email below. And always go to fern.org for finding more information regarding how these tests and other strategies for providing optimal patient care will improve patient outcomes and allow for us to optimally utilize our limited healthcare resources. Thank you again for participating in this educational program.